All right. So we kind of already said this, but I'm gonna read this and just kind of recap and make sure that based on what that video just said, that it all makes sense to you guys. Insulin is a hormone. It's made in the beta cells of the pancreas, and one of its main roles is to help regulate or control blood sugar. And we just saw how that takes place, right? When there's enough insulin in the body, it helps to keep your blood sugar from going too high. So we always talk about homeostasis, right? We need glucose for energy, but if we have too much, we're toxic. So just like all the other, all the other things in our body, we want our pH to be maintained. We want our glucose to be maintained as well. So in people who don't have diabetes, these blood sugars are very carefully and tightly controlled, staying within safe and healthy range. So do I have, and if you don't want to share, you don't have to, are any of you guys type 1 diabetic by chance? Anybody have any insulin resistance or any kind of things that they want to share about? Okay, so in our class population, all of this is happening constantly and we don't have a clue, right? It's all, we feel fine, we're awake for class. I mean, some of us are awake for class, but we're here and we're functioning and there's no issues. So these are in our healthy patients and our blood sugars remain in a safe and healthy range. After a person without diabetes eats a meal or snack, the pancreas releases insulin. The insulin then signals muscle, fat, and liver cells in the body to absorb that glucose from the bloodstream to be used for energy. In this sense, insulin is like a key that unlocks the door of the cells to allow glucose to enter. You can also think of it as a storage hormone, since when there's more glucose than the body needs, insulin helps the body to store that excess glucose in the liver to be used at a later time. Insulin also signals the liver to stop releasing glucose into the bloodstream, and it helps shuttle amino acids and fatty acids into cells. So we all agree that insulin is not a bad thing. Insulin is something that we need. When people are put on insulin, they freak out because it's given kind of this negative connotation. But in a normal sense, we all have insulin and we all use insulin every single day. We don't use exogenous insulin. We don't inject ourselves with insulin, but it's being used in our bodies constantly. We all would agree, right? Okay. So it's manufactured by the beta cells. We already said all this, but you got to kind of understand it before we move on. It controls the storage and utilization of amino acids and fatty acids, and it lowers blood glucose by inhibiting glucose production in the liver. Okay, so glucose. We're talking about a new thing. Remember, I said don't get these grouped up in your head. So insulin we know is the hormone. Glucose, we've already kind of said what it does, but we're going to recap that as well. When we eat, our body starts working to process glucose. Enzymes start breaking down the glucose so we can use it in the body, along with fat. Glucose is one of the preferred sources of fuel. People get glucose from bread, fruit, veggies, dairy, and it helps create the energy that keeps us alive. The pancreas, which produces hormones, including insulin, is an integral part of how our body deals with glucose. When we eat, our body tips the pancreas off that it needs to release insulin to deal with the rising blood sugar levels. Okay, so I said that whole thing like 3 times, right? So remember when I told y'all should kind of teach yourself stuff, act like you're teaching somebody? I want y'all to be able to understand that process well enough to tell somebody about it, because you're not going to be able to educate your diabetics if you don't have a clue why we're giving them this medication, right? Because we're not just giving it to them to lower their glucose. All right, this is just a picture kind of like the same that little guy drew. I'm super impressed with his drawing skills because that one time I tried to do math with y'all with my mouse, it was a hot mess. He did it very effortlessly. All right, so in MedSurg 2, have y'all really got into learning about diabetes, about the patho and the disease process, or not really? Okay, everybody's heard of it just based on family and life, right? So there's 2 types of diabetes mellitus. There is, if you want to just make a side note, there's something called diabetes insipidus and it has nothing to do with glucose. Okay, everybody heard that? Diabetes insipidus, totally different disease process. So diabetes mellitus, you can have type 1 or you can have type 2. So type 1 is a chronic condition, and there is an insufficient amount of insulin produced by the beta cells. So that storage hormone, that hormone that's telling our body what to do with the glucose, it's not being produced. So if it's not being produced, what is happening to these people's blood sugar levels without knowing anything else? What's happening? They're way up, right? Like way, way up, because they're getting all of this. If they eat a piece of cake, let's talk about the cake. I don't want to talk about cake. Y'all already know that because I told y'all yesterday that I don't like to talk about cake or Skittles. But let's just say I'm eating cake and I'm eating a whole lot of it, and I have type 1 diabetes, and my pancreas is not producing that insulin. And if it is producing, it is producing it in just minute amounts. So my sugar is going up significantly. And what happens if our glucose is really high? What do we say? What happens? Everybody unmute and tell me.
Toxic levels.
Toxic levels. So our patients with type 1 diabetes, you can't live sustained. You can have a 500 glucose here and there. I mean, it's dangerous, obviously. You could live with it here and there, but if every time you eat, your sugar is 500 and 600, your cells are being destroyed, okay? So that is not sustainable. So would you say, just based on what you know, that type 1 diabetics are usually insulin dependent or usually not insulin dependent? Talking about external insulin.
Insulin dependent?
Yes. Your type 1 diabetics are almost always insulin dependent because if they can't produce it, we have to give it to them, right? Everybody's pretty clear on that? Okay, so type 2 diabetes, this is what most of your patient population has. Type 2 diabetes is less insulin is produced by the body or cells become resistant. So either those beta cells stop knowing what to do with the insulin, and they can't do that storage transport thing as that normal body mechanism is, or the body is making it, the pancreas is making it, but it's not making it in such a way that it can sustain that homeostasis. Does that make sense? So, do you think for type 2 diabetics, are these people always insulin dependent? No. So if it's more of a resistant issue, we might could attack this from a different route, right? Pharmacologically, we might can attack it from a different route. Now, is it sometimes will your type 2 diabetics end up on insulin? Yes, absolutely. Whenever when diet fails, and we're going to talk about this, when diet fails and all of our oral hyper, whatever, your glucose drugs, I can't get it out. When your oral anti-diabetic drugs fail, these patients may end up on insulin, but it's not nearly as common as it is in your patients with type 1 diabetes, okay? So about 90 to 95% of the cases of diabetes are of the type 2 variety. Many can be controlled with diet, exercise, and the addition of an oral hypoglycemic drug. Everybody feels pretty good, pretty clear before we move on? Okay. All right, have y'all learned this yet? The 3 symptoms, the 3 P's, symptoms of diabetes. This is one of those things that y'all need to remember forever. Patients often, you know how we talk about blood pressure being the silent killer, and people don't really know that they have high blood pressure until it's like super duper duper high? Glucose is kind of the same thing. When your glucose is low, when it's really low, you feel really bad. But when it's high, unless it's like really, really, really high, you don't necessarily feel a lot different when your sugar is 200 versus 100. You don't feel a whole lot different. But your patients are usually going to present with 3 complaints when they're diabetics. They're going to have polydipsia, which means they're really, really, really thirsty. Do y'all know these terms or not yet? Okay. So think about like Fun Dip. If you're eating that, you know how Fun Dip's got the powdery stuff. If you just poured that Fun Dip stuff in your mouth, you would be really thirsty, right? So polydipsia is extreme thirst. Polyphagia is eating large amounts of food, just hungry all the time, just wanting to eat. And polyuria, you're urinating a lot, and that's increased urination. So none of those are really, you wouldn't say those are like life-altering symptoms, right? Not really. I mean, if you got to pee a lot, you got to pee a lot. If you're thirsty, you get a glass of water. And if you're hungry, you just usually gain a little bit of weight. So, but when your patients present with this triad of symptoms, they often, we're going to look into seeing we're going to start checking their glucose and seeing if they're diabetic. All right. I feel like y'all already know this. But risk factors for type 2. So usually type 1 is diagnosed early in life, right? Because it's more of a pancreatic issue. It used to be called juvenile diabetes, but sometimes it's not diagnosed until, 20s, 30s, early 30s. So type 1 diabetes is not usually for the older in age. So that's type 1. Type 2, your obese patients are at an increased risk. Older age, family history. Do y'all know what gestational diabetes is? If you have diabetes when you're pregnant, you're a lot more prone to have type 2 diabetes, as you get a little bit older. If you're not physically active, African Americans, Hispanics, Native Americans, and some Asian Americans are at an increased risk for diabetes as opposed to your white population. Okay, so we've talked about some of this already, but we're fixing to hone in on some little different parts of it. So okay, if we're thinking of our little umbrella, okay, we're going to talk about, actually, all right, so we're going to go ahead and talk about insulin, so we're going to talk about insulin as treatment for type 1. Insulin can also treat type 2, but in a little bit, we're going to talk about some of those other anti-diabetic drugs that we're going to try first. So insulin is not going to be your first-line treatment for type 2 diabetics. Everybody understands that? So we're going to go ahead and talk about it, but kind of keep a separate little box in your head, okay? So we know after all the talking that I did and after looking at our, watching that video, that insulin activates a process that helps glucose molecules enter the cells of striated muscle and adipose tissue. We know that it promotes protein synthesis. So insulin has an onset, a peak, and a duration. Now remember the first week of school I said we'll talk about these later and they'll be a whole lot more important and they'll make more sense whenever you have an example. So the onset is when we first start to experience, think of it as like a little hill, right? That onset is when we first start to see a result. It first starts acting. Peak is the most that medication is going to do. And then the duration is how long it lasts after it goes down that hill from the time of that onset until it is no more, it's not doing anything in your body. So in regards to insulin, this matters a whole lot because especially your patients with type 1 diabetes, you are going to need to know with the different types of insulin that we're going to be giving them, they're going to need a steady amount all the time, right? So we're going to need something with a longer duration, something with like a 12-hour duration. But then whenever they eat, what's going to happen to their insulin? Everybody show me with your hands. What's going to happen with their insulin when they eat? Oh, excuse me. See, I used it interchangeably. What's going to happen with their glucose when they eat? I apologize. Their glucose is going to go up. Their glucose is going to go up. So their need for insulin is also going to go up, right? Do we have 12 hours to wait for that to work? Or we need it to work pretty rapidly? We need to go ahead and get something rolling, right? So a lot of our patients are going to be on a baseline long-acting insulin for that duration. And then we're going to have them on another fast-acting insulin for those times that they eat. Does that make sense to you guys? Okay. So insulin controls type 1 diabetes. It's sometimes given in type 2 diabetes, and it is also used for severe diabetic ketoacidosis. So ketoacidosis, remember we talked about that toxicity? Diabetic DKA is when those levels are so high. I'll post a little video if y'all want to see the things that start to happen when that glucose is just really, really high. So DKA is of concern for patients with type 2 diabetes, but it is especially of concern in your type 1 diabetics, okay? Side note with insulin, this is super weird, I know, but when your patients are severely hypokalemic, that's low potassium, right? When they're severely hypokalemic, we give IV, we give glucose and insulin together, and it increases their potassium. That's pretty cool, huh? So that's a treatment outside of diabetes, type 1 or type 2 that insulin can be used for. Okay. There is a scale in your book, and normally, like, this will be the only time, I say the only time, I hope this will be the only time in pharmacology that you really need to know the onset, peak, and duration, because it very, very much matters. So these are the types of rapid insulin, and y'all see that they start working within less than 15 minutes. So these would be given if our patients have a very high glucose and we need to bring it down quickly, or if they just ate and we're administering it with meals, right? You'll have to remember these other names too, but you see that log, think about the logs floating down the river rapidly, okay? You'll at least remember those two. They're rapid acting, which means less than 15 minutes. And they don't last typically longer than 3 to 5 hours. 5 is stretching it, okay? So they start working fast and they're out of your system fast. That makes sense? This chart in your book is on, if somebody finds it before me, let me know. Let's see.
It's 497.
Thank you. Page 497. You need to know that chart. So this is just one that I pulled off the internet, but the drugs are essentially the same. Your short-acting insulins, often also given with meals. Intermediate are usually used morning and evening. You know, we'll give them in the morning and at night, and they'll help with that baseline insulin level. Then you have long-acting insulin. How often do you think long-acting insulins are given? How many times a day? Usually just once, because they're lasting a really long time. You see there, if you look on there, do you see the onset is 30 minutes to 2 hours, but you see that duration is 20 to 36 hours. So we're not giving it longer. Actually, it's black up here. It should say onset, peak, and duration up here at the top on that bar. And then you have premixed, you have combinations of these long and short-acting insulins. Okay? All right. So without looking at this page, what do you think is a adverse reaction of insulin? Everybody can unmute for a second. So we know what it does. So knowing what it does, what do we think as nurses we're looking for? What is the most common thing that would be an adverse reaction? Hypoglycemia. Yes. Do we know the signs and symptoms of hypoglycemia? Do y'all know those yet? Okay, we can't take care of our patients if we don't know them, okay? So being sweaty, being foggy-headed, diaphoretic, kind of like woozy, lethargic, slow moving, dizzy. All of those are signs and symptoms of hypoglycemia. So if we gave our patient, if we gave our patient Lantus, even though it's long acting, and we go in there before breakfast and we have a hard time rousing our patient, and they're moist, their gown is moist, our first thought should be to check their glucose, right? We're not calling a rapid response immediately. We're going to see, we're going to know they're exhibiting signs and symptoms of hypoglycemia, so we're going to check that sugar, okay? Talking a lot today. I'm thirsty. Hold on. So hypoglycemia is the number one. It's the number one. Hyperglycemia is less common. It's one of those idiosyncratic. Remember we talked about those idiosyncratic reactions. Your body could do this little weird thing, and sugar could actually go up, but that's not very often at all. Neither is an allergic reaction, because your body makes this endogenously already, right? But those are possibilities. It's going to be contraindicated in patients who are already hypoglycemic, and we're going to always use it cautiously. Basically, all of our drugs are used cautiously in patients with renal disease and hepatic impairment during pregnancy and during lactation. That's starting to be a theme that y'all are seeing, right? Okay. So I'm going to pause right there for a second. So those are insulin. That is pretty much it for insulin. Y'all understand what it's for. We understand what it does in the body. We understand that there's several types. And we understand that the onset, peak, and duration are incredibly important when we're administering these drugs. All right, if you look in your book, I am debating. I'll let you know something by tonight, because I have a call out to one of the instructors to kind of see. You see all those subcategories if we're making our umbrella underneath the insulin chart on page 498. If we're making a little umbrella, these are all of our oral anti-diabetic drug classes that are going to go underneath there. It's a lot of them, huh? You have biguanides. You have glucagon-like peptide agonist, sodium glucose linked transporter 2 inhibitors. You have gliptins. You have thiazinolide. I always butcher that word. Thiazolinodiazides, TZDs. We're going to just go with TZDs. We have alpha glucidase inhibitors. We have amylinomimetic drugs. We have sulfonylureas. Then we have second generation sulfonylureas. And then we have meglinotides. That is a lot. And then we have some random ones on the back. Okay, I don't think that I'm going to make you be able to classify those by classes. I don't think I'm going to make y'all do that for this. But I am going to need you to at least know some of the biggies. Like when we talk about, if you go to page... let's see. I'm trying to find it. 1 second. Okay, see these drugs right here on page 494? I'll let y'all get there first. It has some very specific nursing actions as related to those specific drugs. I am going to need y'all to know that. So I'm going to read those to you really quick. And I'm going to probably just pick out a few drugs in each class, that I want you to remember. And I'll let you know that by this afternoon. Because per your syllabus, Y'all are supposed to be able to classify drugs, but we also want to be realistic in our expectations. And we're more concerned about y'all knowing and being able to care for your patients appropriately than just being able to say this drug's in this class. You got to know what the class does, and So I'm going to read these out to you on page 494 and 495, and I need y'all to pay really close attention to them, and I will let you know specifically what drugs we need to know. Okay, so metformin, you for sure need to know that drug. The other name for that drug is glucophage. Metformin. The patient is instructed to take metformin 2 or 3 times a day with meals. It's instructed to be given with meals because it causes nausea, and it often causes some GI upset, nausea and diarrhea often. For weeks, the provider may add the maximum day, and then they'll add something, the sulfonylurea. Extended release once daily with evening meals and should not be crushed or chewed. So any of your meds that are extended release, we're never crushing or chewing them, okay? Because they're not being released in that timely manner like they're supposed to, in that sustained release way that they were meant to be given. So metformin is one of those drugs, and it's in here somewhere, and we'll talk about it a little bit in a minute. But when patients are on metformin, it often interferes with dyes that they're getting for diagnostic procedures. It could have a negative effect on the kidneys if it's administered with those dyes. So we need to know if our patients are on this, and we need to be mindful of their education in regards to when they're on, if they're getting any procedures done. That's going to be one of your jobs as a nurse, is to tell them hold this 24 hours in advance and for 48 hours after. And we'll find some specifics on that later. So depending on the way different meds work, that determines if they're given with meals or if they're not given with meals, okay? So you have your SGLT2 medications. They should be taken at the same time each day. But we don't ever take two of these at once. Most medications you're not going to take 2 at once. And the biggest example, I'm trying to find, I'm flipping back and forth. Give me 1 second. Okay, see under sodium glucose linked transporters on page 498, Jardiance. These all end in OZIN, but that Jardiance and Farxiga and Anvicon are all pretty common drugs. If you want to make a note by that. Next to the glucagon peptides, those are all subcutaneous drugs. Those are given weekly, okay? Okay, so metformin is not going to drop their sugar if they're not eating with them. Okay, it's more of a longer acting medication. Your thiazides, Actose, those drugs will drop their sugar and cause hypoglycemia within 30 minutes. Actose and Avandia, they're on page 499. So if you want to think, you need to be in the zone when you give these drugs because they will drop their sugar. And if you think the zone, these are the ones that start with T, okay? Y'all see that? Sulfonylureas are given with food. And you need to know those first generation drugs only. Okay. That's all I want to tell you about those for now. So at least those drug classes, okay? Like we're probably not going to have to do the other ones. The biguanides, the SGLT2s, TZDs, and sulfonylureas at the bare minimum. I'll let you know about the other ones. Because I'm kind of feeling like if we can at least know those, then that knocks a big chunk of them off. All right, let's see. So when we're given these meds, I'm going to kind of go through this quick because I feel like y'all know this because based on we said our patients might be diaphoretic. We said that they might be, you know, a little bit confused. So your job is to pay attention to those little details with your patients, whether you're given agents or you need to scan, assess mucous membranes. Why are we looking at their mucous membranes? Why you think? Based on the signs and symptoms of elevated glucose.
Because they can have the polydipsia.
Okay, so if they're extremely thirsty, what will their mucous membranes look like? Very good. Super dry mouth. We're going to pay special attention to any cuts or sores. If your patient has something that just will not heal, sometimes that's a clue of diabetes. If they have recurrent yeast infections, that's a sign of diabetes. We want to know about their dietary habits, their family history. We want to know about their symptoms. Whenever we are given these medications, we want to document the type and the dosage of insulin. We don't just say insulin because we saw like classifications just on, right? And we want to, so we want to know, oh, that's and it's 5. Well, it's not great. And that, you know, for the last, 4 weeks every day, it's not as emergent as somebody who normally runs 100. Does that make sense? So knowing their baseline is important. Y'all know the normal range for glucose in a non-diabetic patient? Those are terms that we got, things we need to know all the time. 70 to 110. Some of your literature is going to say 70 to 100, but just keep that 70 to 110 range in your head. We need to know if our patient is compliant. Are they eating, a whole cake when they get home? And we're steady increase in their meds, but their thought process is, oh, they up my meds. I can have another piece of cake. We need to be able to know these things about our patients. Of course, assess for signs and symptoms of hypoglycemia. administer that supplemental insulin based on blood glucose per the sliding scale. So remember whenever we did our little practice, and it said if your glucose is this to this, give this amount. You have to pay very close attention to those details so that you're given the correct amount of insulin. Notify, the general rule of thumb is we're going to always notify the healthcare provider if glucose levels are greater than 400. We want our patients to have optimal response to treatment. We want to reduce their fear. I'm not going to lie to you, I'm not even super scared of needles, but the thought of giving myself a shot creeps me out. Like, I'm cool with somebody else doing it, but I don't want to give myself a shot. So that is a big deal when you start telling somebody you now have to give yourself a shot 3 times a day. So you can understand why those people are sometimes non-compliant. I don't want to drink a dang shake. I surely don't want to give myself a shot, you know? So you need to be mindful of those things as you encourage your patients. You need to try to reduce their anxiety and fear, and you need to make sure that they understand the implications of not doing it. You never want to scare your patients into doing what you want them to do or what the doctor wants them to do. But even though I don't want to give myself a shot, if my alternative is losing my foot and going blind, I guess I'm going to suck it up. You see what I'm saying? So those are things you need to educate. Tread lightly, but be a good educator so that your patients understand those things. Let's see. So, and we want them to understand their regimen of medications. We really want to educate on using the correct insulin, especially, so they make the little pens now. Have y'all seen the little insulin pens? They're lovely. I'm going to show y'all in class tomorrow. You just turn the dial. It's written on the side. You don't have to draw it up with the needle. You just turn it and you say you want 2 units, and you give a little shot in your belly. They're beautiful, but guess what? They're about at least quadruple the price of the bottles of insulin. Does our patient population always have that kind of money? Nope. Does Medicare always pay for it? Nope. So at the end of the day, yes, those are options, and maybe throughout our lifetime that'll be the only option. But right now, our little patients who can't even see that well are getting their magnifying glass. You remember how hard it was for y'all to put that plunger at the correct? It wasn't hard, but remember y'all to put the plunger in the correct place when we were drawing up that insulin? Think about some little 80-year-old eyes doing that with their shaky hands. Kind of sucks, huh? So be mindful of all of those things. Read the label. Make sure that if you're in the home setting, you're saying keep this one here and this one here. You know, help them figure out a way to be safe. Because if you accidentally administer, so long-acting insulin will usually give like more units of it, you know, like 20 units of long-acting insulin like Lantus. But if we give 20 units of short-acting insulin, and what's going to happen to our blood sugar? It's not controlled over 24 hours. It's plummeting. It's dropping like really, really fast. And then we have a hypotensive emergency. So keeping those medications separate and your patients knowing the difference. That insulin is not just insulin. There's different types for sure. All right. I want y'all to read the box on page. I had them all tagged, but I can't seem to find them now that I want to tell y'all about them. Okay, regular insulin, this is on page 492. Regular insulin is clear, whereas intermediate and long-acting insulins are cloudy. So they do look different. The clear insulin should be drawn up first if they're mixing them together. And you know, the clear insulin is going to be drawn up first, and then we're going to pull up the other one. We're going to give those together at times to decrease. We don't want to give them 6 shots a day. If we can give them 3 shots a day, it's going to be more comfortable for your patient. Do not mix or dilute glargine with any other insulin or solution. It's a long-acting insulin, but it can't be mixed, okay? And Lantus for gargling. I've never heard anybody call it gargling. We'll call it Lantus. On page 494, it's very important to know that exposure to stress, such as infection, fever, surgery, or trauma, may cause a loss of control at this level in patients who with oral diabetic drugs. That normally have glucose control, when they are injured or stressed, those glucose levels will shoot up, okay? Should this occur, the primary health care provider may discontinue the use of oral drugs and administer insulin. So a lot of your patients who are not insulin dependent will be in the hospital. It's also your job to encourage them that because we know this is your body's response to stress and illness and injury and steroids and all of these things, this is temporary. This is not forever. So we want to be the person that educates, in regards to that too, that they're not just bummed out and driving themselves crazy like, oh, I'm going on home on insulin and I'm going to be on it forevermore. That's not always the case. It's not once you take insulin, you have to take it forever. That is a myth, okay? We always want to check the expiration dates. We want to rotate the vial between the palm of our hands. Like this, we're not shaking it up, okay? We don't want a whole bunch of bubbles in it, but we do want to make sure that it's nice and, mixed appropriately. Let's see. Rotate injection sites. We don't want to use the same site repeatedly. That is the same for when we put a patch on. We don't want to cause any lipodystrophy of that area, and we don't want to cause any unnecessary or undue irritation. You want to record the site. So you don't just say you gave their insulin. You say that you gave it in the right lower abdomen, okay, or the right upper arm. We have the disposable needles, like y'all played with the other day, the orange needles. We have the pens that have a special syringe inside of them. And some patients are going to have an insulin pump. A lot of your type 1 diabetics have an insulin pump, or some of your extreme type 2 diabetics. And it's just a pump that attaches to them. It's a little sub-Q device. Instead of having to continuously give themselves shots, they change that needle out like once a week or once a month, depending on their manufacturer's instructions. And it's got a little pump that delivers that medication as ordered. And they can push a button when they eat and say, I ate this many carbs, and it'll deliver appropriately. That's not appropriate for everyone, but it is a very good thing for people who need it. Let's see. We always want to obtain their blood glucose levels during hospitalizations. If you're testing their urine, it's always going to be from their second void. If your patient is confused, so they'll usually be lethargic when their sugar is low. But sometimes that presents as confusion as well. They might not just be, they might just be a little loopy-doo and kind of out of it. So we never want to give oral fluids. Okay, so our first response, remember I said, I would usually give them some juice, if their sugar was 59. I think we were talking about that the other day. I said my first response would be usually to give them some juice, do some of those things that we know will bring up their sugar. But we're not going to give oral fluids to somebody to terminate their hypoglycemia. And if they're not swallowing, if they're like totally, what I think about, have y'all ever seen Steel Magnolias? Whenever they give, I can't think of her name, Julia Roberts, whenever they give her that juice and they're like pouring it in her mouth and she's kind of like, you want to make sure your patients are coherent enough to take in that medication. To take in that juice or whatever. We don't want them choking to death on top of being hypoglycemic. So you need to use your nursing judgment there, okay? Diabetic ketoacidosis is treated with fluids, correction of acidosis and hypotension, and low doses of regular insulin to get those glucose levels down. Your patients might have anxiety. We've already talked about that. We want to help them gradually accept the diagnosis and begin to understand the feelings that they're having. This is not a, it is life-changing. Like when you go, y'all know, I mean, it may not revolve around y'all's life as much as it revolves around mine, but a lot of people's lives revolve around food. Like when you go to a party, you eat. When you like food kind of holds a special place in a lot of people's heart. Like they cooked for their loved ones, they have a party, they celebrate when somebody dies, we bring food. Like food is a big part of our culture. So when you tell somebody, oh, you really shouldn't have that, you really can't do that anymore, you have to start, it's kind of like a punch in the gut. Like it's like, okay, well, that's just great. So it's not something that they're gonna always be like, okay, well, I have diabetes, let me change my lifestyle. No, it's not always that easy. It's the same as smoking. We know it's not good for us, but people still, when I say we, I don't smoke, but it's a common knowledge that smoking's not good for you, but it doesn't mean everybody's just quitting. It's the same way when you're diagnosed with diabetes. I feel like I said all this already. Educate on the storage of insulin and the purchase of needles and syringes. So we are going to dispose of our syringes in a sharps box. We're going to either make sure that our patients have a sharps box at home. Some people use laundry detergent bottles, something that cannot be poked through and cause injury. But normally, if they are put on insulin, we're going to supply them with a sharps container and give them all of the instructions on how to properly dispose of those needles. And most bathrooms at public places accommodate that as well. You'll see sharps box on the walls in some public bathrooms and stuff. We want to talk about the recommended diet that they've been given. We want to talk about some insulins must be refrigerated. So that also means on top of changing their diet, they're starting to bring a little cooler with their insulin in it. And that's no fun either. That puts a hamper on your day, especially when you're 30 years old, or, even when you're 70 years old. Nobody wants to carry around, oh, got my insulin in my backpack. Oh, left it at the movies. Let me go back. All of those things are inconvenient, and we want to make it as, we want to educate them as best as possible and make that blow a little bit less. At the end of the day, we want therapeutic levels to be obtained, and we want their blood glucose to be normal or near normal. We want to recognize those adverse reactions. We want to reduce their fear and anxiety, and we want them to demonstrate their coping with the diagnosis. We want them to have a positive outlook. We want them to verbalize their willingness to comply. We want them to understand the drug regimen and be able to tell people, this is my long-acting insulin, this is my short-acting insulin, and this is why I take both of them. We want them to be able to, we want to actually watch them administer these medications and do it in a safe manner. All right, we're getting there. Y'all still okay? Y'all still with me? We're almost done. I touched on the oral anti-diabetics already. They're used to treat type 2 that's not controlled by diet and exercise alone. So diet and exercise are first line. Oral anti-diabetic agents are next. They're not effective for treating type 1 diabetes, remember, because type 1 diabetes is primarily an insulin issue. If we don't have insulin, we can't, no matter what we give, if your body doesn't make it, your body doesn't make it. So these are those main classes that I told you about. You'll see them here. And the assessment is pretty much the same as it is for insulin, right? Weight, blood pressure, pulse, respiratory rate, mucous membranes, sores, cuts, healing, all of that is sounding like it sounded with the other drugs, right? Adverse reactions, significant weight gain or weight loss, because some of these medications are causing GI upset and diarrhea. And some of them are curbing our appetite, our patient's appetite, so they're not wanting to eat. And then vice versa, some of them just blow you up, and you gain weight when you start taking them. Your diagnosis as related to everything we talked about: confusion, deficit fluid volume, anxiety, ineffective breathing pattern. And I said all this, I'm not reading it again. Okay. This is all the stuff that I didn't realize I had a slide about it. All the stuff that I was reading to you out of the book, remember? Oops. That's what all this is. Okay. When your patients have an immediate hypoglycemic reaction, we're usually going to give them, we're either going to do a glucose, if it's in a non-hospital setting, you're going to give glucose under the tongue, let it absorb. We instruct a lot of patients to keep those in their purse so that, and wear a bracelet. That way, in case they have an event, someone can take care of that. In the hospital setting, we usually give a half an amp of dextrose, which is basically sugar. If our patients are extremely hypoglycemic, that is immediate treatment. Okay. These are signs and symptoms. Oops. Can y'all see my cursor, or do I just point to stuff and talk? Can you see it moving? Okay. At the bottom where it says ineffective breathing pattern, I need to make myself a note. I'm gonna post that little video about DKA, but these are some of the signs and symptoms of diabetic ketoacidosis. Unexplained hyperventilation. Your patient starts breathing. Your patient starts breathing like that. They're just so tired they can't put one foot in front of the other. They're not their typical self. They have some major GI symptoms. Those are signs and symptoms of DKA. So, and I'll post a little video about that at some point today. Ketones. So if your patient has diabetes, we shouldn't have glucose in the urine. But when your patient has diabetes, it often spills out into the urine, and then they'll sometimes have ketones as well. So that's sometimes how patients are diagnosed. If they're not getting blood work done often, and like a female, let's say a female goes in and she just constantly has a yeast infection. She's pretty young. She feels okay. She doesn't really know what's up. And they do a glucose on her, a urine sample on her, and she's got a lot of glucose in her urine. That's a red flag for that physician that we might have something else going on. And then we would do, a CBC and an A1C. Y'all know what an A1C is? Okay. No, A1C is a measurement of glucose over a 3-month period. So when your patients are like, oh, my sugar's been so good, it's been so good, because they were good that morning, that 3 days leading up to their blood work, we're not fooled. We see a 3-month average. Now, it is not measured in that 70 to 110. It has its own numbers, okay? I think it's like 5.2. You have to look it up in your book. I think it's like 5.2 to, it can go all the way up to like 10, which is horrible. And we want to keep our patients, don't quote me on these numbers, but they're close, but I want y'all to look them up. We want our patients to be controlled, our diabetic patients usually under 6.5, and then someone who's not diabetic is usually under 6, I believe, but I'll have to look those up for you. But it's A1C is that long-term measurement. Let me look it up now because I don't want to be recorded telling y'all wrong. I know it's something like that.
Is it on page 490?
Probably. Let's see. Yes. So you see there, diabetes. Oh, look, I was right. Check it out. Diabetes 6.5 or greater, the hemoglobin A1C, 6.5 or greater is considered diabetic range. 5.8 to 6.4 is considered pre-diabetic. And the normal range is 4 to 5.7. And y'all see the difference. So like in your book, Remember I told you that's 70 to 110? In your book does it 70 to 100. So kind of keep that in mind. On test questions, it's not going to be that 10, that close to where you're trying to decide. You'll be able to tell if your patient's glucose is reading high or not. And then a glucose tolerance test is something different. That's when they drink something and then their glucose is tested, afterwards to see how that regulation is taking place in the body. So yes, 490, that's an important chart. All right. We talked about all this. Oh, should I think I'm leaving y'all? I said all this already. It's very redundant. Okay, true or false? Insulin is a hormone produced by the liver that regulates how glucose gets into cells and is used for energy. True or false? What y'all think? Okay. Nope. Pancreas, not the liver. So a lot of y'all missed an easy true false on your test. When I put true false on there, I'm trying to give y'all some points. Remember that one about Lovenox? It said enoxaparin is a low molecular weight heparin. It is. That is used for, and I made up some junk, it's used for blood clots, to prevent blood clots. It's not used for any other reason. It's not used for, I don't remember what I put, but it wasn't right. So make sure when you're reading your true and false that the whole statement is true. Or if something is wrong in that statement, then it's false. True or false? Protein and fat metabolism also require insulin. See some right answers. True. Yes. And true or false? Diabetes mellitus is a chronic condition in which insufficient insulin is produced by the pancreatic beta cells, or in addition to less insulin produced, the body becomes resistant to insulin. True. And it can be type 1 or type 2, right? All right. Let me stop presenting this. Make sure y'all don't have any questions, and then we'll take a little break. So how y'all feeling? Yeah? Doesn't seem as overwhelming except for the lots of drug classes. That's the only thing. Even those are a little bit, they're harder for me because there's not really anything to differentiate a lot of them. But y'all understand your role as a nurse, right? Y'all understand what y'all need to do to take care of patients who are on these medications. And then I told y'all that you have to know the onset, peak, and duration for insulin. Like that's a forever kind of thing. What else? Questions, comments? I feel okay? Yeah? Okay. Take a break until, you want to do 9:55? That'll work? Okay. Take a break till 9:55, and then we will start lecturing on chapter 44.